Welcome to the Expert Roundtable podcast, where we connect frontline clinicians with top thought leaders to facilitate discussion on key issues they face daily.
So today's podcast will focus on mantle cell lymphoma with Drs. Zachary Epstein-Peterson, MD from Memorial Sloan Kettering Cancer Center. Dr. Epstein-Peterson, if you could introduce yourself.
Good morning or good afternoon. Thank you for having me. My name is Zach Epstein-Peterson. I'm an attending physician on the lymphoma service here at Memorial Sloan Kettering Cancer Center in New York. My clinical and research interests include non-Hodgkin lymphoma with a particular focus on mantle cell lymphoma and T-cell and cutaneous lymphomas as well. I'm privileged to work with colleagues on investigator-initiated and industry-sponsored trials to move the care forward for these patients. And my clinical practice is focused on patients with these conditions as well. And thank you for having me today.
Okay, thank you very much. And our other expert today is Dr. Karen Jacobson, MD. You could provide just a brief intro for yourself.
Yeah, thanks so much. I'm Karen Jacobson. I am from the Dana-Farber Cancer Institute in Boston, Massachusetts. I am part of the lymphoma group at Dana-Farber, but my other job is as the medical director of our immune effector cell therapy program, which is our CAR T-cell therapy program for blood cancers, but also for research efforts in solid tumors as well.
And Dr. Bose, if you could introduce yourself.
Hi, Julie Bose. I'm the Chief of Hematology Oncology at University of Nebraska Medical Center, and my clinical research is in lymphoma.
So the topic is relapsed mantle cell lymphoma, current standard of care and recent developments. So what do you think are some of the important considerations when it comes to choosing recently developed novel therapies over the standard of care in relapsed patients with mantle cell lymphoma? So Dr. Jacobson, if you could start off.
Well, yeah, I think you obviously what the patient got in the front line is important in making second line decisions, especially if more and more centers are starting to use chemoimmunotherapy in combination with a BTK inhibitor in the front line. That has the potential to remove BTK inhibitors from standard second line therapy for these patients. For those patients who have seen a BTK inhibitor in the front line, we do have CD19 CAR T cells available for eligible patients in this setting. Brexacaptogene autoleucel is actually FDA approved for any mantle cell lymphoma, regardless of number of prior lines of therapy or type of prior therapies. So this might be a good group of patients to take directly to Brexacel. We recently saw the approval for lisacaptogene maraleucel in mantle cell lymphoma, but the FDA had limited that to patients who had received prior chemoimmunotherapy and a BTK inhibitor and were receiving liso-cel in the third line. The other exciting drugs that are standardly available for patients with relapsed mantle cell lymphoma include pirtobrutinib, which has activity in patients who have progressed on ibrutinib, acalabrutinib, or zanubrutinib. And then there are lots of therapies that are in clinical trials, and it's always appropriate to consider referral to a clinical trial for a patient with relapsed mantle cell lymphoma. We've seen good activity of the CD20 bispecific antibodies in this disease, and those those were done as single agents, but there are additional trials being done in combination with other drugs that are active in mantle cell lymphoma, including things like lenalidomide, which of course can be offered to patients on its own. And then there are the BTK degraders and the BCL2 degraders, which are all in clinical trials and showing interesting results. So, I think your considerations when someone relapses with mantle cell lymphoma is what did they get frontline? Are they a CAR T-cell therapy candidate? Have they seen a standard BTK inhibitor? And then are they amenable or interested in clinical trials?
Yeah, I would echo a lot of what Dr. Jacobson said. It's highly individualized to every patient's situation. You can see 10 patients with relapsed or refractory mantle cell lymphoma in one day and it's 10 different trajectories of disease. For example, meeting someone who had 8 years benefit from auto transplant, is very different from someone who's, say, primary refractory to BR from frontline setting. And then, of course, bearing in mind their BTKI exposure, I think is super important here to consider what the next therapy will be. And then, again, the disease trajectory and understanding the disease features, we think that's also very important. For example, Ki67, blastoid pleomorphic, TP53 status, all of those would be concerning disease markers that may push us more towards a CAR T approach versus a BTKI approach, depending on what their prior exposure is. I would say if they're BTKI naive, probably the standard of care would be a covalent Bruton tyrosine kinase inhibitor like acalabrutinib or zanubrutinib. If they're BTKI exposed, pirtobrutinib is very reasonable as well, as is lenalidomide, venetoclax, or a clinical trial. So that's kind of the immediate first step at that point. Dr. Jacobson alluded to CAR T cell therapy with brexucabtagene and lysocabtagene. We're reaching for those quite frequently, especially for patients with adverse disease features where we're just not confident in the durability or the longevity of a BTKI response, or for BTKI exposed patients, doing something for a brief period of time and then really going to CAR T at that point if they're eligible and have the right kind of patient fitness for that. So those are the therapies kind of actively being used right now. Dr. Jacobson also mentioned a lot of promise in BTK degraders. The second generation BCL2 inhibitor, sonrotoclax, from Beijing, is also showing a fair amount of promise. And so those are the things in development that we're hopeful for the future. I think the sequencing of things is very patient dependent, and more tools in the tool belt makes for longer conversations. But a lot of it's playing the right card at the right time and trying to think about what makes sense based on how things are behaving, the localization and extent, and of course goals of care, because patients can be therapy or side effect averse or maybe more that may or may not matter to some patients if they want to just be aggressive and try to treat the lymphoma in that way as well. We refer, depending on the practice pattern at each center, certainly early referral for consideration of CAR T and starting that conversation is pretty critically important, especially because of the timelines for collection, apheresis, and administration of the agent. So certainly, again, it's center or community dependent what the workflow is there. But early conversation from the lymphoma provider and early referral, I think, is really helpful here, just to have those conversations, even if you're not dead set on committing someone to Brexucel or Lysocell at that point. Hearing the perspective of the different services, I think, can be helpful as well. Geriatric assessment is increasingly important as well because of the demographics of this disease. So if that's an option, it can only help the situation to understand the geriatric syndromes and any interventions there.
So for relapsed mantle cell, typically we would use a BTK inhibitor if they haven't had it in their frontline therapy as one of the first options, with or without an anti-CD20, or in some cases possibly with a BCL2 inhibitor as well. So again, the bovine regimen. For patients who have already failed those treatments, then you would look at other clinical trials, or CAR T cell would be another option if they were a CAR T cell candidate. And there's a couple different commercial CAR T cells now for mantle cell. And for the appropriate patient population who is a little bit younger and has already failed upfront therapy as well as a BTK inhibitor, then those are very appropriate treatments and do have some very long-term disease-free survival. So if the patient is eligible for CAR T in a relapse setting, that would be definitely something I would try for. Most of the time, they're not necessarily eligible for an autologous stem cell transplant if they haven't already had it as part of their initial therapy. And of course, we're always trying to look for new agents for mantle cell or a different combination of agents to see if we can improve the outcome for these patients, as they are unfortunately very difficult to treat.
So we discussed earlier about the frontline approaches being slightly different for older versus younger patients. Do the same sort of things apply in the relapse patients, or is it just pretty much focused on what they've received before, and like you say, a very individualized approach?
Well, I think that age is sort of a less significant cutoff when considering some of the alternative therapies in the second line, but other medical comorbidities can definitely help you choose one therapy over another. And as Dr. Epstein-Peterson said before, that patient preferences can also help guide you in terms of picking one therapy versus another. So there will be patients who are much more interested in therapies that they can get locally, therapies that have fewer side effects, therapies that carry less risk. And there are other patients who will say, I want the therapy that can give me the longest time in remission, regardless of risk. And so I think, all of those things will be factors into picking and choosing between these therapies. And I think that is what Dr. Epstein-Peterson was describing that this is really an individualized approach. There's not necessarily a standard order of operations for each of these drugs, but we have lots of things to pick from once we understand what the goals and the resources for the patient are.
I would echo that for sure. Age is still a factor, but it's a little bit, it really is individualized. There's young 68-year-olds who can go right to CAR T. There's older 65-year-olds who are actually not candidates because of comorbidities. And so we very much take a lot of that into account. And then again, the motivation and it can be a hard decision, right? I can tell you can take a BTKI indefinitely and you could have minimal toxicity and do great with that. And there are patients who are on BTKIs for many years benefiting from that with kind of tolerable side effects. At the same time, it's indefinite therapy and CAR T is a lot to bite off, but it's generally just a one-time infusion and there's definitely side effects that come with it. But some people may even like that approach or prefer that to say it's a little bit more aggressive, but if I can have time off of therapy, that would be beneficial or preferable for me as well. And so these are, nuanced discussions and definitely want to reiterate, looping in the CAR T providers early to have their perspective because they may see things differently from a lymphoma provider in terms of how do they view these decisions and such. And I think one of the issues that we've heard about is kind of determining CAR T eligibility, which is, I think, different from auto transplant eligibility, and kind of not automatically excluding someone from that with a different mindset from auto transplant from before. Again, I haven't necessarily seen it myself, but I know from speaking with people in the community that sometimes that determination, it really is different from auto transplant. And so early referral, or at least early discussion of that makes sense, depending on how the conversation goes. Again, how is the disease presenting itself? What are the disease features that make you maybe more or less confident about what the next therapy durability could be? So.
Yeah, so, it's different considerations on what they've received before. If they have already received a BTK inhibitor and then relapse on it, then, there's no real reason to do a different BTK inhibitor unless you're using pirtobrutinib, which would be the difference between one type of BTK and another. And so that would be an option also in relapsed as well, depending on what they've had before. And, there's always new things that we're looking at or trying to combine new agents. And that's of course, the clinical trials of the future.
All right. Well, that's, again, excellent summary. And thank you very much for your time.